Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast, the show where we explore the dynamic world of chronic pain, neuroscience, physical therapy, and the opportunities for transforming how pain care is delivered. I'm your host, Dr. Joe Tatta, CEO of the Integrative Pain Science Institute, where we train physical therapists and other practitioners on integrative whole-person pain care. Today, we're honored to welcome Dr. Trevor Lentz, a prominent figure in the field of physical therapy and an assistant professor in the Department of Orthopedic Surgery at Duke University School of Medicine. Dr. Lentz's extensive research has focused on improving the care provided to individuals suffering from chronic pain, with a particular emphasis on non-pharmacologic treatments and addressing healthcare system barriers. Dr. Lentz has an impressive academic background, holding a master's in physical therapy, a master's in health policy management, and a PhD in rehabilitation science, all from the University of Florida in Gainesville. Additionally, he has completed a postdoctoral fellowship in musculoskeletal outcomes research at the Duke Clinical Research Institute and a faculty fellowship in implementation science at Vanderbilt University. His outstanding work has been recognized with funding from prestigious organizations such as the National Institutes of Health, the Foundation for Physical Therapy, the Duke Endowment, and the Center on Health Service Training and Research. On today's episode, we delve into the world of integrated pain management programs. We'll explore the definition of these programs, learn about the real-world experience and outcomes of these programs, as well as dissect the major implementation barriers that both providers and systems are experiencing. Dr. Lentz will also share with us the unique and innovative strategies these programs are employing to deliver integrated pain management, as well as his insights on where this vital work is headed next. Okay, without further ado, let's begin and let's meet Dr. Trevor Lentz and discuss integrated pain management programs. Hey there, Trevor. Thanks for joining me this week and welcome.
Yeah, thanks, Joe. Great to be here.
So a lot of people know your work from Duke and a lot of your work in psychologically informed care. Probably most clinicians know your work from the OSPR Yellow Flag, which if people haven't heard of that, they should Google that and take a look at it. But I also came across some great work that you did in the May 2023 in the Journal of Pain that I want to make sure we point people to, because we're going to be talking about this, for most of the episode here. So for those of you that are out there listening and you want to kind of open up your browser and take a look, we're talking about a particular paper that Trevor wrote called Overcoming Barriers to the Implementation of Integrated Musculoskeletal Pain Management Programs, a multi-stakeholder qualitative study. So we'll link to that in the show notes, but first, thanks for the work. And I know your whole team has put a lot of work into that, but tell us how that kind of work came about and really what the purpose of it was.
Yeah, it's kind of an interesting background for this particular project. We were funded through the Duke Endowment, and if you all are not familiar with the Duke Endowment, they fund a lot of different type of work, in particular around healthcare, and gave a lot of money to Duke University to try to understand how to better manage the opioid crisis. And they were particularly interested in the opioid crisis in North Carolina and the U.S. South, and they had a number of different projects that they wanted to fund. We were one of those. A lot of the projects were really geared toward addressing, secondary and tertiary prevention as it relates to the opioid crisis, opioid misuse, opioid use, trying to understand how we manage patients that are already on opioids, how we get them better options, better access to buprenorphine, things like that, to reduce some of those effects. Not a lot of those projects, though, were focused upstream. And so ours was really one of the few that I think is part of that portfolio that we're focused on, well, how do we prevent patients from being exposed to opioids in the first place? And maybe even more importantly, as we start talking about trying to reduce the prescription of opioids, what options do we give patients? Because as we know, opioids can be effective for some patients, and by pulling some of those things away, we need to be able to provide better options so that we're not left with this other crisis of undertreated pain. And so that was really, I think, genesis of our project, the motivation behind it was how do we better manage people who have pain to try to reduce this exposure to opioid use? And they were particularly interested in integrated pain management programs. And these are comprehensive programs that address, I guess, the best way to describe it is the biopsychosocial issues related to pain. And so they wanted to understand, well, how do we? What are some of the implementation barriers for programs like this, and how do we overcome some of those barriers? What do these programs look like in real life? How do we essentially create more of them so that more people have access to treatments that are safe, effective, and really accessible. And so that's what we really set out to do, was try to get a better understanding of what these programs look like and some real world experiences with their implementation.
I'm just trying to think back. I mean, obviously when a paper like this it was published in May, but you and your team have been working on this for a while. And I do remember back, when the opioid crisis kind of hit, one of the biggest concerns was, well, we're starting to taper people down or not prescribing these medications at all. So what's the alternative? And I think this paper really speaks to that in some way, because when you look at integrated pain management programs, they're really saying this could be an alternative, or perhaps even exist alongside someone who is currently taking an opioid. So really important work. So integrated pain management is not something that our listeners are unfamiliar with, but there are different types of integrated pain management. So maybe kind of give us either your definition of it, or maybe what you looked at or recognized in the study that you did.
Yeah, you're right. There are a variety of different ways that it can be defined: integrative, integrated pain management, and I think even throughout our project, there was a lot of confusion or questions about exactly how we would define that. And I think the important part here is that we tried to take a relatively broad brush to this. We wanted to look across all of these different programs that were out there to manage pain. And so we didn't want to define it too narrowly, such that we could pick up on programs that were providing really good pain care and where we could learn a lot from them. So really the way that we operationally defined it is that they were programs that delivered care consistent with the biopsychosocial model. They tended to integrate two or more psychological, physical, or integrative services to address musculoskeletal pain, and typically within a structured program. So these aren't services that are just being provided concurrently. It really needed to be within the context of an integrated program where they were being delivered in some integrated way. That's how we tried to define it. And again, we were pretty loose in that definition as we were looking across a variety of different programs that we encountered.
Was it easy to find these programs? Because I know there's some debate on these programs used to exist kind of more in the early 90s, and they kind of have fallen out of suit. And I think your paper talks that a little bit between the lines of trying to figure out, well, potentially what are the barriers and can we overcome them to bring them back in some way?
Yeah, in short, the answer is no. I mean, there are definitely a number of programs out there that I think are fairly well known, but it was actually somewhat difficult to identify programs, and just by their nature, I think a lot of these are within large academic health systems or large non-academic health systems. And I think in large part because of the resources that are required. So where we really found some challenges was in identifying a broad, variety of different types of programs, rural programs that provided care in urban settings. A lot of them tended to be focused within academic health systems or other large health systems. And so that's where we really found, I think, the challenge in identifying them. Most of our approach was to reach out to programs that we were familiar with or that people that we had talked to were familiar with, and then ask them, hey, what are the programs in this space? Who are the people that are doing really great work in the integrative or integrated pain management space? And then we kind of took it from there. I think we ultimately spoke to about 30 different programs across the US. A lot of these I mentioned that the goal of our funder, a lot of them were in the southeast, but we also had pretty good representation out in the Midwest and the West as well, a couple of programs up in the Northeast. So we tried as best we could to get a representative sample, understanding that these are going to be concentrated within certain areas where those resources exist. And maybe we can talk about that in just a little bit. That is one of the challenges, I think, in delivering this level of care for pain management, is that you really have to have access to some of those resources, and it creates challenges for delivering it in more rural settings.
Yeah. Maybe you can give us an idea of like what one of those programs looks like, or maybe you can name it or not. But I think people are interested because you mentioned it has oftentimes one or two psychological components and one or two physical components. But as I read through your paper, I also saw chiropractic and acupuncture. So I was wondering, are those, I guess, disciplines you saw within one program or kind of scattered throughout different programs? Give us a kind of a
Yeah, that's a good question. We actually saw it scattered pretty well throughout a lot of different programs, and in fact, I think a lot of the programs that we talked to, it kind of depended on what stage of development they were in. Early on, these programs, are typically focused on delivering 3 or 4 maybe different types of treatments. So let's say, for instance, acupuncture, chiropractic care, kind of behavioral-based therapies, and then as those programs grow, they start to offer more treatments. So it could be Reiki, it could be physical therapy, mindfulness, a lot of different type of nutrition based programs as well. So some of it was dependent on what stage of development they were in. But we really saw, particularly in the programs that were pretty well established, a large menu of different options that were available that include a lot of different complementary and integrative treatments. I think just off the top of my head, acupuncture tended to be one that was fairly common. Chiropractic care, physical therapy, some type of cognitive behavioral based treatment as well. I think we tended to see those most commonly. And then there were also things like I mentioned, nutrition and weight loss. And we actually saw a medical legal partnership, which was somewhat interesting as well in a FQHC in Austin, Texas, People's Community Clinic. So a variety of different different treatment offerings that were both, I guess, more traditional management and then your complementary approaches as well.
Well, I think everyone's excited to hear all those disciplines and maybe those multimodal interventions coming together. However, I do think it's important that we probably start to talk about some of the barriers, because this is the reason why these are not widespread, is that there are barriers both from providers, from practitioners and payers and other stakeholders. So what's the major implementation barrier that you discovered in the research?
Yeah, we actually, in talking with the group that we did, we identified 4 main barriers, and they tended to focus on issues of payment and reimbursement, and that's kind of the one that's probably most salient. There's organizational change, so really changing the culture around pain management, which really tends to be siloed. How do you get people to start working together that haven't worked together in the past? Developing a business case. So there's sort of the ongoing finance, but there's also the startup. How do you get one of these programs off the ground? And then just a number of regulatory hurdles, whether that is related to credentialing or other sort of nuanced, state specific or payer specific hurdles that's related to regulation. And so those tended to be the 4 main categories that we outline in the paper. I think, when we look from a provider perspective, I think the major pain point for a lot of providers were things that we're probably already familiar with: utilization management, prior authorization needs, utilization reviews. For these programs in particular, what we heard a lot of was that these regulations on multiple visits are not the inability to pay for multiple visits to different providers on the same day was a major issue, because these are integrated programs. These are providers working in the same physical space. So the fact that an insurance company wouldn't pay for a patient to see multiple providers really makes this incredibly difficult to do, or at least very inefficient. There were, I mentioned kind of organizational change. We heard a lot about the need to develop buy-in from different healthcare disciplines that aren't used to working together. And it wasn't so much that there wasn't the belief that these other disciplines would be helpful. It was just really a lack of familiarity. So it's physicians working with acupuncturists, working with physical therapists, working with chiropractors. And, I think traditionally you would see those as people that are vying for the same patient population. But here they're all working together, and they may not really truly understand what each of them does. And so bringing these disciplines together and helping them to getting them to develop rapport and helping them to understand what each did was really a challenge, I think, for most programs. And it even came down to something as simple as just getting everybody to document on the same electronic health record system. So it's really simple, practical, pragmatic issues as well. But really the organizational, the cultural change, I think, was the biggest issue for the providers. And then I think if you if we think about some of the payer perspective, that really came down to primarily reimbursement. And, I think it would be of no surprise to anyone that reimbursement isn't often aligned well with services that we know to deliver the highest value. And I think particularly in this case, we're talking about delivery of services that traditionally haven't been reimbursed very well. And so how do you then bring all of these together to create a program that is self-sufficient, solvent? And that is really a major problem. I mentioned the startup funding. Most of these programs were started either through charitable donations, grants, or one-time investments from healthcare systems. But to keep that going to keep that funding going, it was really challenging for a lot of these programs. And it came down to being able to demonstrate some eventual return on investment. And some of that may have been through cost prevention, which is really difficult to do. So, saying that if you're helping to manage a patient who has pain conservatively, and that reduces the risk of some adverse event related to opioid use or a hospitalization or an emergency room visit, sometimes it's a little difficult to project those cost savings. But that's what a lot of these programs try to do. There's also these non-financial returns as well. So reducing provider burnout. It's incredibly challenging sometimes for, we talked with a lot of programs that were embedded in primary care, or at least had not so much embedded in primary care, but had referrals from primary care. And so, for primary care providers, managing chronic pain can be incredibly challenging. And so, reducing burnout, having another option to send patients who have chronic pain, that really helped, I think, to sell the value of a program like this. So I think those were some of the major challenges that we tended to see, the implementation barriers. One of the other I'll just mention real quick is related to quality measurement. That was something that we heard from payers quite a bit is, how do we measure quality? Is there a good quality measure that really captures all of the different dimensions of high quality pain management? And that's an area that I think still has yet to be resolved, but certainly something that we heard from a lot of payers.
Wow, there's a lot there. I want to maybe unpack a couple of those points, but just to review for our listeners. So navigating coverage, payment and reimbursement, potential organizational change, making a business case to stakeholders, and overcoming regulatory hurdles. Sounds like that's really, kind of the meat of a study, if you will. I have one kind of, as you're talking, just one overarching question that I'm curious about, because I know you actually interviewed, there's a qualitative study, you actually interviewed these stakeholders. They were insurance companies and, various other stakeholders. Do you get the sense that they actually value integrated care in some way?
I think so. I think there is general agreement. I don't know that we talked, I'll put it this way. I don't know that we talked to anybody that says this is a really bad idea. Mm-hmm. The integrated part and the non-pharmacologic focus.
Right.
I don't know that there was any of I think we had, over the course of the entire project, I think we did more than 100 different, or we engaged over 100 different stakeholders. And I don't know that we ever heard at all that, comprehensive pain care is not the way to go. So I think everybody's, at least that we spoke to, on board with the fact that pain management needs to change. It needs to move away from, pharmacologic management as the primary, the initial way of managing pain, or even as the primary way of managing chronic pain. I think where there is a lot of debate is, well, how exactly do you do that so that it meets the needs of every party? Because it has to meet the needs of the payer and the health system and the provider and the patient. And, unfortunately, those perspectives aren't all aligned, other than, yes, this is really important. We need to figure out how to do it. So don't know if that answers your question, but I think there's a general agreement that this is a good idea.
Yeah. There's also something in your paper where you mentioned that there's almost like this paradox happening where things like medication, surgery, and interventions are actually covered quite readily and quite easily. Yet the things that we're talking about here that, make up an integrated pain management program oftentimes are not. So, I often wonder if we're kind of in this like holding pattern until we figure out how to bring all these stakeholders together and kind of make them quote unquote happy or satisfied in some way, both from, I think, a provider delivery perspective, as well as probably from, a value-based financial perspective.
Right. Yeah. And I think you're right. That does need to align. I think throughout our project, probably the closest that we saw to that, to an example of that, is a program that's at the University of Vermont. It's a collaboration between the University of Vermont and Vermont Blue Cross Blue Shield, and they've come up with a really innovative, it's relatively novel program, bundled payment program for integrated pain management. And so it's called the PATH program. And so what they've done is, I think, come closest to aligning payer, healthcare system, provider, patient perspectives and goals and needs in developing this program where there is a fixed payment, there's a bundle for a defined program, a 13-week program where patients are coming into this program. It's based on group visits, so it's a group-based program. They have cohorts that enter this program. And it tends to work out well for both the payer and the healthcare system as well. So I think the thought is that we probably need more programs like that, or at least more arrangements like that, because that does bring a lot of those perspectives and those needs in alignment. Unfortunately, we don't have enough of those right now, I think, but hopefully with examples like what we're seeing at the University of Vermont, Blue Cross Vermont, we'll start to see more and more of those options. And they're showing pretty good outcomes as well for some of their initial cohorts.
That's interesting for people to consider, because you have to kind of set aside the fee-for-service model to create a program like that, which there are some, I guess you could call them experimental programs happening within the Medicare system, the MIPS, but
Right.
none of them have yet to really, I guess, take off the way we hope they would. But it sounds like the fee-for-service system could be a barrier to the implementation of integrated care in some way.
Yeah, and I think that's probably the other thing that we had pretty good consensus on. Not only that we needed a better way to manage pain, and that we needed to do it in a holistic way, but that fee for service is just a major barrier. And I think we heard that from payers as well, and that the way that is set up right now doesn't really incentivize this type of approach to pain management, at least not in a coordinated way. And so I do think that we need to move beyond that model to really make this work. And it requires a bit of risk. I think it requires a bit of risk from not only the payer, but also the healthcare system side as well. Absolutely.
As a researcher, I know you have a lot of insight into some of the self-report measures that healthcare providers use and researchers use. And you mentioned that some of these integrated management programs were trying to prove that, for example, there was less opioid use or less visits to the ER. So you can kind of prove that where there's a cost saving in the long term. I'm wondering if you recommend people pursue that, or do you think it's more feasible, so to speak, that you can, take measures of quality of life, physical health, mental health, and then use that to have discussions with stakeholders who are interested?
Yeah, it's a good question, an interesting point. I think what we had heard from a lot of these programs, and I touched on this a little bit earlier, is just how difficult it is to sometimes measure, evaluate, project some of these cost savings. And, we found that a lot of programs, particularly as they were starting up, tried to, I think, steer clear of that route. It was really more to your latter statement there about showing that there is benefit from a quality of life standpoint, showing that the not quality of life of the patient and of the provider as well, the physician or the physical there, people that are doing things that are well aligned with what their goals are. And so I think that's probably where we tended to see a lot of these programs going, is that because that's something that you can also show pretty quickly, or at least it's I guess relatively easy if you compare it to how difficult it is to measure costs. Relatively easy to show that there is some improvement in physical function or disability or quality of life or satisfaction or engagement and things that people really like to do, improvements in pain coping or self-efficacy or self-management. Or even reduction in opioid use to some extent. But I think a lot of the programs that we saw were really focused, I think, on making the argument that this just improves people's lives. And this is, and that in and of itself has a lot of value. And And I think for a lot of these programs, that was an effective argument. It wasn't all about the dollars and cents necessarily. I think there needed to be some value that the administration saw in keeping this program around. And that's really the easiest way to show it, I think.
Yeah. I want to connect some of your previous research to this particular study, the OSPRO yellow flag, which I point people to quite frequently for measuring, psychological risk factors. If people really kind of dig into your research in that tool, it provides not only kind of the vulnerabilities or the risk factors, but potentially also resiliency factors. Mm-hmm. And both of them are important in pain care, although it's interesting, there may be more or some data building around resilience factors or resilience factor
mm-hmm.
approach. Do you have a sense when you look at these programs, are they kind of targeting vulnerabilities and risk factors for treatment, or are they targeting more building resilience in people through like more of a wellness perspective? Because oftentimes like the complementary and integrative approaches tend to be focused more on wellness, where maybe something like traditional CBT may be focused more on, the let's say the vulnerability of depression, so to speak.
I think a lot of the programs that we talk to, they naturally recognize that chronic pain isn't necessarily something that you solve or that you get rid of. And so I think the overarching or the overwhelming approach to management for a lot of these programs is about building resilience, is about building self-management skills. I think there's certainly, a lot of them integrate the cognitive behavioral based, addressing pain coping skills, things like that. So I think it's probably a little bit of both. But many of these programs, and in fact, they'll talk with patients about this. It's not so much solving your pain or fixing your pain, which we know is not something that we're likely able to do, but it's about living better with your pain. And so it's building up that resilience, it's building up quality of life despite the fact that you have pain. And so what we saw was really a lot of work focused on, how do you improve wellness? How do you improve quality of life? How do you do the things that you want to do? To improve your well-being despite the fact that you have pain. So I do think it was a little bit of both, but I think a lot of them were forward-looking in the sense that, we really just need to build resilience, as opposed to only addressing the coping issue.
So where would you like to see this work go in the future? Do you already have other studies planned or next steps into kind of broaden this?
Yeah, I think there are a couple of different areas. I talked a little bit about the quality issue, and that seems, to me like one of those areas that is the low-hanging fruit, identifying, getting some consensus around quality measures, what exactly defines these programs. A lot of the payers that we talked to, they said, well, we don't really even know what integrated pain management is exactly. How do you define it? We understand what an episode of physical therapy looks like, or an episode of chiropractic care. We know what an injection looks like, but what exactly does an episode of integrated pain management look like?
That's a great question.
And some of these questions they brought up just seem like, wow, this is really something that I think we could potentially tackle, moving forward. This project in particular, I think, is really geared. Our audience is, healthcare systems, payers, providers, to some extent, but it's really more about policy. What do we need to do from a policy perspective? And I think, my role as a researcher has traditionally been about collecting data and analyzing data. But in this case, it's really just as important to try to disseminate this information and make sure that it's getting out in front of the people that need to see it. I think another area, and I'll point listeners to some case studies that we've done alongside this paper. There are 4 different case studies that we've done on different programs that I think provide pretty good examples of how exemplary integrated pain management programs look like in different settings. And I think we probably need even more of those, these proof of concept examples that this can be done efficiently, it can be cost effective, and in particular showing these collaborations or these payment arrangements between payers and healthcare systems to make these programs work, whether it's a bundled payment program or some other value-based arrangement. I think the more that we can show that this type of approach works, that it can be cost effective across a variety of different settings, is really important. And I think the final thing I'll say about future work, and I mentioned it at the beginning, is rural settings. How do we improve accessibility of these types of services, these types of treatments? We started this program, or we started this study rather, really right as COVID-19 was hitting, and a lot of these programs were shifting toward telehealth, and some of that, as you all recognize, some of that early on, I think everybody was trying to figure out how to do that effectively, and some programs I think did that really effectively. Some programs, had to, they couldn't deliver physical therapy, they couldn't deliver chiropractic care, they couldn't deliver certain services because they were not able to do that via telehealth. So there are, I think, opportunities using telehealth to reach more rural audiences, but there are also challenges associated with that as well. Broadband, do you actually have access to internet, out in more rural areas? So that's an area that I think is a great opportunity for future research, and one that I'd like to explore.
Yeah, I mean, it's important when, large portions of our population don't have access to a mental health provider or a physical therapist. So that telehealth component can be really important. As a pain researcher, you're also a physical therapist. I want to make sure we just kind of look at this from a physical therapy lens, so to speak. I'm wondering if to kind of get your opinion or gauge your opinion on kind of the growing trend of primary care physical therapy. If you think in the realm of policy, as you mentioned, if we were able to potentially expand that, maybe in the ways that we've seen in the military, if you think that would have a positive impact on not only developing these programs, but I guess our role as practitioners within these programs, maybe potentially even leading these programs.
Yeah, I think in short, I absolutely support that, and this could probably be an entire another episode with about this topic. But I think it really is a great opportunity for physical therapists to be embedded, and I think it does open up opportunities for us to take on a larger role in these types of pain management programs. I mean, essentially, when you look at these programs, it is embedded physical therapy with, either primary care providers or specialists. And so they are, in many cases, they're right there front and center and treating patients day one, which I think is really important. It becomes even more important when you have people kind of outside of the integrated pain management context, where, a lot of these are more patients with chronic pain. I mean, obviously with the acute pain, avoiding, hopefully, the exposure to opioids and providing options like physical therapy early on. I think we have a much better understanding now that the timing is just as important. The timing of access to non-pharmacologic care, including maybe specifically physical therapy, is really important. And it has a meaningful impact on what happens down the line for a lot of these folks. So I think, it certainly has implications for trying to keep people out of or outside of the need for chronic pain management. But it also gives us a good opportunity to function in a role that's much more front and center. We have a program, it's not so much a chronic pain management program, but there is one like that at Duke. It's called the Joint Health Program for people with osteoarthritis, common chronic pain condition. So, in that program, physical therapists operate as a quarterback, if you will, helping to oversee assessment and management of these patients, and are responsible for referring out to other different types of services like nutrition and psychologically based treatment. So there are a lot of different models out there that I think we're starting to see more of those. I think they do create value. And I think it certainly is an opportunity for us to get more involved in chronic pain management.
Yeah, I mean, the value, I think, is the big piece that I think as a profession, we have to kind of get better at, one, learning ourselves, and then two, educating, the public and stakeholders. Again, I want to make sure to point everyone to Overcoming Barriers to the Implementation of Integrated Musculoskeletal Pain Management Programs. You can find it in the May 2023 in the Journal of Pain. Trevor, I want to thank you for being here, and thank you for your work, of course, in pain management and physical therapy, and let people know how they can learn more about you and follow your work.
Yeah, sure. I'm on Twitter or X at Trevor Lentz PT, and you can also just Google my name at Duke, and it will bring up a Duke Scholars page, which has some of my work on there. I do want to just acknowledge the group that I worked with on this project. We do have a website where a lot of this information on this entire project is sitting. It's freely available. We were very intentional about making sure that there were no paywalls, that that would restrict access to all of this work. So if you Google Duke Margolis Center for Health Policy is the group that I worked with on this. Rob Saunders, Jonathan Gonzalez-Smith, Katie Huber, Will Blesser, really great group of health policy experts that helped us on this project. And also Christine Gertz, who's here in the Department of Orthopedic Surgery with me. We do have a page that has all of this information on it. So you can go that. It's pretty easy to find on Google, Duke Margolis Center for Health Policy Pain Management project with my name, and you should be able to find that. But yeah,
Excellent.
Thank you.
Excellent. So if you missed that, you can, of course, hit rewind or let your fingers do Googling. And of course, you can always find all the links on the show notes at the Integrative Pain Science Institute. We'll include the links for Trevor's scholars group at Duke, as well as the paper. I want to thank Trevor again for joining us this week. Make sure to share this episode with your friends and family on Facebook, LinkedIn, Twitter, Instagram, where everyone is talking about pain management and integrated pain care. I'm Dr. Joe Tatta, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.